I would like to not only welcome each of you, but also to welcome those who are watching online and on television. We're delighted you have joined the European Health Conference. We're having a good time here in Prague, and we trust that what you are seeing will be of help, inspiration, and benefit to you as well. Our next speaker is Dr. Gary Fraser. He was the chairman of the panel yesterday, so he got a brief introduction. I'll make it slightly longer. Dr. Fraser is on the faculty at the School of Public Health at Loma. He's also a member of the School of Medicine. He is a practicing cardiologist and as well has his doctorate in epidemiology and is probably best known as the director of the Adventist Health Study. He's been associated with the Adventist Health Study for many years now, and he has contributed so much to our knowledge of the impact of lifestyle, especially in the evidence and data that comes from that study. He joined it when it was Adventist Health Study. He's now the director of Adventist Health Study 2, which is the current study that is ongoing, and we are very delighted that he is able to be with us. I have had the privilege of knowing Dr. Fraser for a number of years. He and my parents shared a fence line for quite a few years in Loma. So, Gary, we're just delighted to have you here, and we welcome you to the conference.
Well, thank you very much, Fred. It's certainly a delight again to be here in Prague. Actually, my third visit to Prague, and it's never a disappointment. It's a great city. So I was asked to talk about Adventist Health Study, quotes, a healing tool. And that was a title that puzzled me for a while, and still puzzles me a little. But as you can see, in talking with Dr. Ferreira here, we got some understanding, and hopefully we'll have some useful things to say. So let me start directly by saying that if our Adventist health message has any merit, then it should be that Adventists are some of the healthiest people on the planet. Now, I have some slides, and let me see if I can make them work. Oh yes, good. So let's look at some of the evidence, and for those of you who attended the workshop yesterday, there will be a little duplication in the very first part of my presentation, but not beyond that. So the Adventist Health Studies, as you've heard a little bit from Dr. DeRose this morning, thank you, David, has provided some evidence about this. Admittedly, most of our evidence comes from studies in the United States, although there have been smaller studies now a number of years ago in Denmark, Netherlands, and certainly in Norway, and Dr. Funneberg is here down the back, who made a major contribution some years ago. But there's great value, I think, in showing that there is an Adventist advantage. And this becomes part of a larger picture, proving that the choices that we make, the way we choose to live our lifestyle, do really matter. Then Adventists, if that's the case, have something very special to offer the world. So let me start by refreshing your memory very quickly about the kind of evidence that we've been able to provide. I think that's right, there's a little delay. So I don't know how well you can see these, and I've got a little laser pointer here that I can only operate on the center screen, but one of the very dramatic findings that we have noted in our studies, and are very consistent with British vegetarians, is that when you look at BMI, which of course is a measure of body size, there's a huge difference between the strict vegetarians and the lacto-ovos and the non-vegetarians. Having said that, in the United States, even our lacto-ovo vegetarians on average are overweight. But the point is, that in a world that has, in the Western world at least, an epidemic of obesity, then we have got something to say in terms of what a vegetarian diet seems to do to that problem. If we turn our attention to diabetes, we can see that the prevalence of diabetes in the general population in people 20 to 64 is about 8%, and those over the age of 65, this is in the US, it's about 27%. A huge problem related to obesity. So the expected value, if we just apply those figures to our Adventist Health Study population, would be about 14% diabetics. In fact, we have a prevalence of about 5.6%. Even allowing for the fact that there will be some undiagnosed diabetics in our group, let's say allow 3 or 4%, it's clear that the rates in the Adventists are very much lower. And in fact, now if we look within the Adventist population, looking at the vegans, lacto-ovo, pesco, vegetarians, semi and non-vegetarians, you can see that there's quite a trend, and all the vegetarians hang far below the non-vegetarian Adventists with diabetes incidence. If we turn to hypertension and compare it to non-Adventists, the rate of hypertension amongst Adventists in our study is about 44%. Now that might seem fairly high, but remember this is the average age at 62% in a population that's overweight, about only half of them are vegetarian. And the expected rate of hypertension in a similar population of non-Adventists would actually be higher at 52%. So clearly there's something going on amongst our group, and if you look within the various dietary patterns again, it kind of looks like a step ladder going up, and Dr. DeRose showed you some similar results from our studies a few minutes ago. So interesting things are going on here. If we look now at the rate of coronary artery disease, and this is going back to AHS1, and this graph is perhaps a little difficult to understand, but the line here at 1.0 is the line of the non-Adventists in California. This is a study reported from Stanford University, and so by comparison, we have the male and female Adventists at different ages down here. So you can see at the younger ages, the Adventist experience is very much better than the younger people in the general California population. As you get up to the age of 70, 74, you find that still the Adventists do better, but less so. And that's something that we find throughout our data, that the lifestyle advantage seems to dissipate a little bit as you get older, but it still persists. And this is the rate of definite myocardial infarction, just another way of looking at heart disease, and basically we find the same answers. If we turn now to cancer, and this is comparing again from AHS1, it's a little early for AHS2 to do this yet, we look at the rates in our Adventist group for all these different cancers, and I'd like you to focus on this row here. A figure of 1.0 means that the Adventist experience and the non-Adventist experience is identical. And you can see that most of these figures hang substantially below the 1.0. Not always. And so we do find that there's one or two cancers where the evidence that the Adventists do better is not as secure, but certainly most of the common cancers we are finding that the Adventists do very well indeed. Now turning to longevity, and of course there's been a lot of publicity over a number of years now, starting with an article in the National Geographic about the fact that Adventists live longer. And here we look at, this is from our new study, just the rate of death, adjusting for age and sex and race, in the vegans and the different dietary groups through to the non-vegetarians. And again, you can see that there's quite a progression there that's very, very important, I think, and something that we have yet to investigate fully. Back to the old study, the AHS1, and this is a survival curve, starting off with everyone alive at the age of 30, and then the proportion of Adventists who are alive at different ages, and the proportion of the general California population who are alive at different ages. This is for the men, and the difference between these two curves is substantial. It is not due to chance, hugely significant. So the Adventists clearly have a survival advantage. And if you look at women, the same thing is true, although the separation between the curves is a little less, but again, certainly not due to chance. Something important is going on. If we look at it, and we can look at this in many different ways, one way to look at it is the percentage of people, in this case on the left side, men, who survive to the age of 85. And so you can see some of your countries represented here. This is data from back in the 80s and the early 90s when the Adventist data was collected at the same time. And you can see in, let's say, the United Kingdom, about 15% of men were surviving to the age of 85 at that time. The California Adventists, 40% of men, and if they were vegetarians, approaching 50% of men were surviving to the age of 85. If we look at women, in the United Kingdom, about 1/3 of women were surviving to that age, about 40% in the United States, but 54% of the Adventists, and if they are vegetarians, about 60%. So this is the basis, this is the data that's provided some excitement, and I think an increasing interest on people actually not living to be 100. That's not something we ever focused on. It's an interesting statistic, it's something that captures people's imagination, but we're much more interested in moving the whole population ahead by a certain number of years. And on average, it seems like the Adventist men in California are living about 7.5 years longer than their non-Adventist neighbors, and the women about 4.5 years longer than their non-Adventist neighbors. So, just going back to the original question, here we see that when we look at body mass index, diabetes, high blood pressure, I didn't show you lipids, but the same thing is true, there's differences, experience with coronary artery disease, cancer, and longevity, the Adventists are doing better. So, back to my original premise, as measured in these ways, we are indeed some of the healthiest people on the planet. But the question becomes then, does this go far enough? Let's go back to the well-known WHO definition of what is health. It says that health is a state of complete physical, mental, and social well-being. And that's a word I'd like you to remember. So what is this well-being? And not merely the absence of disease or infirmity. That's a well-known definition. So I have not gone far enough in the results I've shown you so far, because I've mainly shown you about the absence of disease or infirmity, whereas well-being is clearly a positive state that a healthy person has more of, in contrast to disease, which is a negative state that a healthy person has none of. And I put up the logo here of the Sanitarium Company, which is an iconic food company owned by the Adventist Church back in Australia and New Zealand. Kathy MacDonald is here, and you'll be hearing from her, I think, tomorrow or maybe later today. And so they have renamed their company recently the Sanitarium Health and Wellbeing Company. So what's all that about? We got involved initially 2 or 3 years ago as consultants to this company and to thinking particularly about the well-being aspect of things. But we soon realized that the literature on this topic was not very robust, that the concepts were not particularly well developed from an academic point of view. WHO tells us in their glossary what they kind of mean by these kind of concepts. In fact, they use the term wellness, and I should say that in the literature there's no great distinction between using the term wellness and well-being. One can have your own opinions about this, but in fact they're kind of used interchangeably. And what they say about well-being is it's the optimal state of health of individuals and groups, and that there are two focal concerns. Firstly, the realization of the fullest potential of an individual, physically, psychologically, socially, spiritually, and economically, and the fulfillment of one's role expectations in the family, community, place of worship, workplace, and other settings. And remember, the definition of health talked about optimal well-being. So this becomes a very all-encompassing definition. One of the problems is that this is actualized and measured in many different ways by all kinds of wellness and well-being instruments that industry has developed, many academic bodies, commercial companies have developed, and there seems to be no commonality. So one of our postdoctoral fellows at Loma University, Dr. Sherma Charlemagne, has just submitted a paper for publication after a careful analysis and a formal review of the practice on instruments that measure well-being and wellness. And here's what she recommends and what she found. She looked at the domains and very carefully measured whether they did actually measure what they purported to measure, and those that were most commonly used across a variety of published instruments. And she found that nearly all the instruments measured emotional health, non-leisure activities, and by this they really mean work. We're not talking about non-leisure academic and learning activities, physical health, and social health. So they were kind of a given. Most instruments measured those. So based on this, and also the definition of well-being, she recommends that such instruments should always include these four domains, which I think are the top four that I have there. But in addition, looking at the definition, she also recommended that we should include the next three, which is economic health, health behaviors, and healthcare access and utilization. Now that's particularly important in a country like the United States, where there is universal health care. It may be less significant. In addition, in the Adventist setting, she recommends that we should also include spiritual health, because of course there are other dimensions that really can be chosen according to the setting or the purpose of who is putting the instrument together. There's also a body of opinion that a life satisfaction scale provides somewhat fundamental data. So that would be our recommended list if one was to develop an instrument, that these should be some of the scales or the domains, as people call them, in such an instrument. There is always the necessity, of course, that such an instrument be relatively brief. You can't put people down to fill out a 20-page questionnaire, usually in a commercial setting. So it seems to me that we as Adventists should have a discussion, a careful discussion about well-being, if we're to take a broad view of a person's whole existence and potential in the many dimensions that are mentioned here, each of which should be lived to the glory of God, our Creator. The usual focus on nutrition and perhaps physical activity, I think, was incomplete, as I think Peter Landless mentioned yesterday, even though they do have great importance. So I think that there's a number of questions that are worth thinking about. For instance, the idea of subjective versus objective ideals of wellness, future risk versus present health, theoretical ideals versus personal goals. Let me just give you a few examples of some of the trouble you can get into, some of the problems as soon as you start to think about this. First of all, the question of subjectivity versus objective health. Let's consider here for a woman who has severe arthritis, a good deal of deformity, presently in remission with good pain control and on good medications, but powerful medications. She has a very positive mental attitude, a mature and satisfying spiritual life, many friends and supportive family. So what would you judge her state of health to be? Subjectively, she may argue that apart from some functional limitations, she has a good quality of life. That's subjective well-being. But objectively, she has much physical damage, increased risk of cardiovascular disease, and some potentially severe side effects from some of the powerful medications she's on. So here she has good subjective well-being, but perhaps poor objective health. So how do you score her overall? That's one question. Let me give you another similar question that I don't have a slide for. Who has the better health? And let me perhaps ask you this. A man who feels real good, but he smokes 30 cigarettes a day. Or a similar man who, under extreme pressure, now does not smoke, but even after a year feels anxiety and a great desire to smoke, such that he avoids many social situations and occasionally sneaks a cigarette, but with a good deal of self-loathing when he does it. So objectively, he's much better in many ways, but in other ways he feels worse. He's got better physical health, he's got much lower risk, but perhaps at the moment poor subjective well-being and quality of life. So you see some of the complications that one can get into. And you know, when you deal with patients, you do find people like this. It happens. So what about present health compared to risk or future health? Let me ask you again another situation. Who has the better health? A woman with a good lifestyle, but with a blood cholesterol of 360, that's about 9 millimoles per litre, pretty high. Systolic blood pressure of 170. We see patients like this. She's on no drug therapy as she feels a great aversion to taking artificial medicines. How about a similar woman? Bad blood pressure, bad cholesterol, but she's been persuaded by her doctor or her family to take medicines, and she now has normalized cholesterol, normal blood pressure, but she feels depressed and anxious about a decision that she believes was morally wrong. So the first person, you could say arguably, has good health at present. She feels good, but she's got very poor outlook in terms of risk. Do we bring that into our well-being? At the moment, objectively and subjectively, or subjectively, she has good well-being, but her risk of future events is really very poor. So how do we factor that into our instruments? We need to think about that. She's at risk of some catastrophic event in the future. Many would say that risk should be a component of physical health, but many of the instruments don't take account of that. What about theoretical ideals versus personal goals? Because you see, a person may not have perfect self-understanding or quotes the right attitudes in their personal goals. They may have an ideal that their perfect life would look like this, but according to some external source, maybe the Bible, maybe science, their perfect life would look actually very different. So how should the feelings and the expectations and opinions of the individual enter into this calculation? What of a man who feels very good? He's satisfied with his life. He has acceptable values of risk factors, but he's somewhat introverted socially and has no interest in organized religion, little financial flexibility. From the perspective of an Adventist ideal, and perhaps a theoretical ideal as well, this man has not reached his potential. Is he then unhealthy despite the fact that he feels healthy? And from a medical perspective, is objectively healthy? And so, to what extent should we try to persuade a person to change based on our special understandings as an Adventist, or some theoretical or academic ideal? So this becomes a matter of ethics, doesn't it, to some extent, when that person feels that he's achieved their personal goals. So there may be a gap between the personal ideals and those based on some external standard. These are all things we need to think about if we're thinking of developing an instrument to use on our neighbours and our non-Adventist friends. If we were to use it on our own population, which also wouldn't be a bad idea, by the way, if we could develop some good instrument, well, then things might be a little different. A final problematic factor is, should we add the scores to come up with some kind of total measure of health? So we have these 8 or 9 domains, each important to well-being. But do we want to come up with one score and say that this person's health looks like this as compared to that person's? Well, that's quite a problem. And let me just point out a couple of things. Let's say we had 2 women with excellent scores on all of the dimensions, except that the one scores poorly on economic and physical health, and the other scores poorly on spiritual and emotional health. Adding the scores of these 2 women gives identical totals. Do they really have equivalent health? See, it depends how you want to weight these various domains. And my suggestion, at least initially, would be to leave the 7 or 8 separate scores rather than to force a separate score, because it's not easy to combine what are really somewhat disparate concepts. However, it could be done, I believe, and it gets a little technical, if we could find some external measure of well-being against which to measure all these things together and give them the appropriate weightings, or if one was willing to take a consensus of different groups to the weightings of the different dimensions. But I suspect if you were to do that, you would find that you would get different answers in different cultures, different answers in young people and older people, different answers perhaps between men and women, and maybe you need to have that level of flexibility. So let me spend the last couple of minutes by just quickly showing what the Adventist Health Study has to say about more on the subjective and emotional side of well-being. First of all, quality of life. And I'm just going to go quickly to some graphs here. This is using a standard scale, the SF12, to measure, in this case, physical quality of life amongst women. The national norms for this, you'll notice that it goes down and down by age. People are less physically well as they get older. But these are the national norms in the purplish color. The blue and the green are Adventist black subjects and white subjects. And you can see at every age they hang above the norm. If we go to the next slide, we look at men and we see very similar things. The next slide is now looking at mental health, women, and you can see people as they get older tend to actually have a little better mental health, except perhaps right at the end. But again, the Adventists are hanging well above the non-Adventists. And this is for the men and the same thing. So there's one important thing that we can conclude from this. The Adventists are living longer, but they're probably living better as well, which is a very nice thing to be able to talk about and conclude. The influence of positive religious coping, or the association between this and depression, is of interest. Positive religious coping is just whether or not under stress and trauma you have a willingness to go to God and seek help and comfort from Him. And there's a whole scale that measures this. And you can see that those that have more and more in religious coping amongst the Adventists have lower depression scores. These are people that were divorced in the last 5 years. And you can see that those that did poorly on the religious coping had much higher depression scores, whereas equivalent people who did well on the religious coping were not actually depressed at all. And finally, here's some interesting data. We have a scale called the Spiritual Meaning Scale. And just put very simply, it's questions like, do you have meaning in your life? Do you acknowledge that there is something higher and transcendental perhaps working through you? So this is not religion, it's more kind of spirituality in a more generic sense. And you'll notice, as you might expect, that the Adventist scores are significantly higher, 6.3, as compared to the non-Adventists. Another important scale is life satisfaction, asking questions like, is my life close to my ideal? If I could live my life over, would I change anything? And it's very interesting to me that the Adventist scores here, and we haven't done a real comprehensive search of other scores, tend to be a little lower. And I wonder if this is due to a little bit to the idea that Adventists have a tendency to perfectionism historically, that we're never quite satisfied with what we can do. But we'll need to explore that a little further before making any conclusions. So what are the practical implications? As Adventists, we're interested both in our own health and that of our non-Adventist neighbours. That goes without saying. Our recent research focus has often emphasised nutrition and to a lesser extent physical activity, but we need a more comprehensive measure of health and must go beyond this, as indeed is implied by our tradition. And a wellness or well-being instrument, such as I've outlined, may be a good basis for a more comprehensive measurement of both our own health and perhaps that of our neighbours. So, in summary, Adventists are arguably the physically healthiest people on the planet. The Adventist health message has always been multidimensional, but this needs more emphasis, I think, because health has many different facets. When helping others to improve their health situation, we need to be sensitive to all of the dimensions and find ways to ensure that a focus on one-to-do aspects does not harm others. A more typical focus on nutrition and physical activity does have a strong basis in evidence, but these are powerful forces for and against good health, but are incomplete. And to measure health comprehensively is to measure well-being. And we suggest that in the Adventist context that this should involve at least 8 to 9 different dimensions. Thank you.